Hello. Hi, everyone. I'm Dr. VanderWel. Welcome to the Eviva MD Weight Loss Treatment Options live seminar. We are talking about weight loss treatment options today. So thank you for tuning in. So who are we? We are Eviva, leaders and innovators in bariatric surgery since, for almost 20 years now. And what we've been doing in this field is, why is this not carrying over here? Interesting. Sorry, everyone. I'm not sure why these slides aren't carrying over. Presentation mode. This is a new one. Just close it real fast. Thank you for bearing with me for exciting technical things. This is the first time this ever happened. Okay, here we go. And we're back. Chris, you'd be so proud of me. Chris is our IT guy. So, all right, let's do this again. Welcome, everybody. This is Dr. VanderWel. We are talking about weight loss treatment options today at Eviva. So, Eviva, we have been doing bariatric surgery for... Okay, why is that not switching over now? Okay, there we go. We've been doing bariatric surgery for almost 20 years and have been leaders and innovators in this field. We did one of the first outpatient laparoscopic sleeves in the world. That was in 2007, as well as the first outpatient gastric bypass. Contributed to a lot of different papers in bariatric surgery. And now we're the first in the Pacific Northwest to do a endoscopic sleeve gastroplasty, the ESG. Why is that not switching over? Okay, there we go. I think that's going to be the key. Yep. Finicky today. Sorting out the problems. So, so this is our practice. We have 3 bariatric surgeons, bariatrician MD. Actually, Dr. Burden has just retired, so I guess that's not necessarily true. Medical weight loss ARMP, 2 RDs, and 2 surgery PAs. Love these people. Love working with them. You'll love them too. They really care about what they love about our patients. They really love what they do, and they're good at it. And yeah, it's a joy to work with. We have meetings on a regular basis where we talk about all the things that are going on, how to keep getting better and better, and any patients that are struggling, how we can help them and support them and get them on the right track as well as we can. So let's start with the picture of why is obesity so hard? Just the 30,000-foot view. And really, I think if we look back, just even the last 30 years, where obesity has exploded across the United States and the world, the United States is not unique in this, but our bodies are really not made to live in the 21st century. They are not. And what they are made to do is survive hardship and scarcity. And it's really nice to live in comfort and abundance like we have now, but that just makes it really hard to manage our weight. So you think about even just 50, 100 years ago, living conditions were considerably more difficult. Climate controlled rooms and working environments were just not really a thing. Our jobs were much more difficult. Our transportation much more uncomfortable and challenging. And the types of food that we ate were much more difficult as well. We were chopping our own wood. We were carrying our own water. Like, these are things that, we just don't really have. It's a totally different world that we live in now in the 21st century, which just makes it just makes it hard to manage our weight. So I break obesity into 6 things: mindset, diet, exercise, psychology, support, biology. And when you struggle with this biology one, you should notice, like, it doesn't matter what you do on this hand, you are just fighting this uphill battle against your body. Surgery is a tool to help us with this. It is not a cure, it is not a magic wand, but it's a really good tool. Changes that uphill battle into a downhill battle. So you're working with your body as opposed to against your body. So you want to lose weight? You can eat less and exercise more, right? That's what everyone always says. Why can't you just do that? It's like they take it to the extreme. That's like the Biggest Loser show, which most of those people went on to gain their weight back, and most of them have gone on to do surgery. Actually, have done surgery on Biggest Biggest Loser contestants. The reason is that this really only works for about 5% of people. Is if you are significantly overweight or obese and you lose a lot of weight, keeping it off in the long term is a 5% rate, which is a bummer. So these are the treatment options, right? They eat less, exercise more, do work harder, do better. And it's the problem with it. The nice thing about it is that it's no complications from that necessarily, besides the complications of just obesity in general. But there's not direct ill problems from that. It's just full of frustration, disappointment, and the results aren't very good. So then we have the next thing that's the less invasive is medication. Usually weight loss of this, I'm going to break this into oral medications and then the injectable medications like semaglutide and tirzepatide. Those are going to be the next category. So the oral medications, which are generally cheaper, easier to get to, less side effects, but they have less weight loss. It helps move things in the right direction. It usually takes away some food noise for people or helps with their cravings. Generally can take the edge off of a lot of things, but I wouldn't say no one's going to say that these medications are a slam dunk for everybody. Some people can do very well with them, but that's not the norm. The durability is okay. You can stay on a lot of these medications for long term and do well. But if you stop them, that can come back, and the weight loss is slow when you're on them. So they can have side effects as well. And so usually the side effects are manageable, and they're done. They stop if you stop taking the medication. So the next class of medications or tools we're going to talk about are the GLP-1 receptor agonists. This would be the Ozempic or the semaglutide, which is Ozempic or Wegovy, or tirzepatide, which is Mounjaro or Zepbound. And these are the newer drugs on the field. It's true that we have been using GLP-1s for over 10 years, but never in the portions, in the quantities, not quantities, but like the dosage quantities that we're talking about now, which is why that's a little bit different to say that what we're doing now isn't that different than what we were doing before. It's quite different in the dosing, in the amount that we're giving people. These, though, have shown fantastic. We're making some really good progress as far as from a medication standpoint goes. Stuff that we're getting into progress we have not seen in a very, very long time. Or if ever. So average total body weight loss for most of these drugs is somewhere between 10 and 15%. The durability of this is probably the big question mark. So really, we've been using these drugs at scale since maybe 2020. And so that means it gives us maybe 4 years at most of long-term data. And what we see is that it is a challenge for most patients. It's close to 50-50. So it's 60% are generally staying on the medication at a year. So that means 40% of people stop taking the medication. When people stop taking the medication, their weight loss, generally about 40% of them gain back a significant portion of their weight loss. About 50, I saw a study the other day, 15 to 20% actually lose a little bit more, and the rest of them stay about the same. So complications aren't, usually you have some sort of GI weird feeling when you first take the medication for that first day afterwards for most people. As your dosing ramps up and your body gets used to it, those side effects, they can get more, and then your body kind of adapts to it and gets a little bit more used to it. So the big issue with these is they're expensive, they're hard to get up, and they're hard to find. Because they're in high demand right now and they're in shortages. We don't really have a lot of long-term data. We have more long-term data on the medications, even the endoscopic sleeve gastroplasty, than we do with these medications. And weight regain after you stop them is a real thing. And making sure that if you want to do these medications have been really cool, and we are excited about them. We do a lot of these in our practice. We think all of these things are tools. And You're just about finding the right tool for for somebody. Um, that is why these things are really cool, but we got to understand how to use them well. Like, so these medications are very strong too. Like, they can suppress your appetite a lot, and not just suppress your appetite, like not make you hungry, but if you do try to eat through it, like it can make you actually pretty sick because it kind of reduces the emptying of your stomach and kind of clamps it down a little bit. So you just can't eat as much food as well. So you got to know how to use that tool well so that you're losing fat and not lean body mass at the same time when you're having weight loss. But yeah, these have been very exciting, very cool tools, and great to have them in the quiver. So there's semaglutide, tirzepatide. So let's talk about, now we're kind of going to transition into the procedure aspect of these tools. This is the endoscopic sleeve gastroplasty, or the ESG, or the endo sleeve. All the same thing. And it's technically non-surgical. There's no incisions, nothing's cut out or removed. But it is an intervention. There's general anesthesia. There is some recovery time, usually about 2 to 4 days. But it's considerably less invasive than a surgery is. With total body weight loss in our practice is average 23%. So usually we see people somewhere between 20 to 30% total body weight loss, depending on where you kind of start from a BMI category. Durability we've found is good. We've seen a lot of good progress here. The studies that have been doing this for longer periods of time, that have thousands of patients, have seen good durability as well. And complications are very rare. So our complications in our practice are less than 0.5%. And those have generally been blood clots, one blood clot, and stricture. So considerations. So it's self-pay. There's very few insurances that approve paying for the ESG. There's limited long-term data in the sense of we don't have 10-year data yet. But the data that we have that's 3 and 5 years out looks promising. We keep getting better and better at this. The recovery is about 4 to 7 days all in all. Most of the time, people, if they get a procedure like on Wednesday or Thursday, they'll take the rest of that week to recover and then be back to work the next week if they want to be. I always tell people the goal of these surgeries is to change your life, not to get you back to work as soon as possible. So it's about figuring out what's going to help you with that. So the way that you do the procedure is that you use this overstitch device, and it's a suturing device essentially that goes down through the mouth with an endoscope, and from the inside of the stomach takes full thickness bites of the stomach in a pattern that then closes down the stomach, which is this big bag, and you take those bites and you close down the stomach sequentially to reduce the size of the stomach. It's just a really cool procedure. It reduces the size of the stomach, so it helps you with the hunger hormone profiles and a bunch of the biologic profiles, as well as reduces the amount of food that you can eat at one time. So, cool tool, very cool tool. So last thing we'll talk about is the laparoscopic bariatric surgery. So this is sort of the gold standard for treatments, for tools, for bariatric, for if you're really struggling with your weight. Total body weight loss is more, 25 to 30%. Durability is very good. Complications are also very rare in our practice. So my laparoscopic sleeve complication rate is also 0.5%. But the things that can go wrong in a surgery, are considerably more than an ESG. But you want to, if you set yourself up for success, the complication rate can be safer than any other major surgery like gallbladder surgery or major hip surgery. The downside is that it's not always covered by insurance, and usually the recovery is a little bit longer than, say, an ESG, so like 10 to 14 days. Usually you feel sore from those poke marks where the incisions are. And the surgery is done in this fashion. So this is laparoscopic surgery. You have these small incisions here, and you use a camera to be able to use these long instruments to be able to do all of your surgery. So the gastric bypass, we'll talk about this one first. This is kind of the grandfather of bariatric surgery. It's been doing this since the 60s. You make a small pouch, as you can see here, small pouch, as you can see here, of the stomach, and then you bring up a piece of small intestine, you connect it there, and then you reduce. And then what that does is, you can see where the red arrow is this is where food goes. It doesn't connect with all the gastric juices, the bile, the pancreatic juices, which are here in the green arrow, until it's partway down the small bowel. And so you bypass a lot of the absorptive capacity of the small bowel. Not only just this part, but there's not as much absorption of nutrients that happens without that breakdown. This is still a relevant operation, still a very good operation. Weight loss is very good. Durability of that weight loss is very good. You do have to take your vitamins. You got to be careful of a couple other things like ulcers or maybe a bowel blockage that can happen, but those are very uncommon, but not zero. About a 4% lifetime chance of that, something like that or more. The next, the one that is probably performed the most commonly in this country and the world is the laparoscopic sleeve gastrectomy, and that's what's also shown here in this picture. This picture, there we go. And that is where you use the small incisions again, and you take that stomach, which is that large bag, and you reduce it down to a small tube, and you remove the extra part of the stomach right here. That part is going out. The sleeve is, I get this question a lot. Well, what are you sleeving the stomach with? Well, you technically don't put anything around the sleeve. You just make it smaller into a sleeve shape configuration. So that is kind of it's sort of a misnomer. You're not actually putting any foreign body like a lap band or anything like that, or something, an actual sleeve inside the stomach. This is a great operation. It's very well tolerated. It's a very safe operation. It works well. It's a tool, just like all these things, and like with any tool, you got to have the right skills to get the most out of it. So, but yeah, we've been doing this a long time, and we have some some great success stories with all of these operations, with all of these tools in general. All right, cool. You say that's nice. What? Okay, well, I'm struggling. I need some help. Even if you don't really know what to do, really, and you're not quite sure what you want to do, here's how you take the next step. Reach out to us at EvivaMD. .com. Contact us. You can see this on our website, and you can use this QR code to take you right to it. What will happen is you'll get set up with a consultation. We have telehealth consultations, which is really nice. We do a lot of these visits this way. Over 30% of our patients come from over 3 hours away. And what's nice is even if you live down the street, it's just so helpful to do telehealth stuff to just get yourself on track and get you help with all the little things that come along with this journey. At that visit, we'll review your medical history, your surgery history, talk about all the options, see what's going to be right for you, and make a plan that's customized for you. And then we'll start the journey. Yeah. So, very cool. Well, thank you everyone for tuning in, and yeah, let's get to the Q&A section here. Let's see here. All right. All right, everyone. Thank you for joining the live Q&A section today. I have some preempted questions that people have already submitted, so let's tackle those guys first. So, here we go. Sarah asks, I had a revision from the sleeve to a Roux-en-Y gastric bypass in 2018. I have since regained 50 pounds. What are my options? Do you do gastric bypass revisions? Thank you for the question, sir. And I'm sorry that you're struggling. And yes, we do. We have, there's all number of options available for you when you're regaining weight after any bariatric surgery. So the first thing we'll do is, we set you up with our team, and we say, okay, how's it going with the general skills of the tool, like food choices, portion sizes, tracking food, what's your activity level, how's your sleep going, how's your stress, and then we talk about the options. Like, okay, we got medication. We can do nothing. Right? We can just work on our diet and work on all the behavioral things. We can do medication. We can do any numbers of, talk about all those options. We can do an endoscopic revision where if you haven't had a gastric bypass, using that endoscopic tool that we saw with the ESG, you actually go in there and tighten things up. Take bites around there and tighten it up and make it tighter. That can give a little bump for people, a little jump start for helping with weight loss. The other options, we can do a laparoscopic revision of your gastric bypass. We want to take a look at everything. We'll do a full work, talk about doing what we do to a workup, like of what's going on in there and how we're going to help figure out, where are the targets that we have for what's going wrong with this thing and what needs to be tuned up. So, yeah, there's always hope. There's a lot of options, and sometimes these things we're just going to keep grinding it out until we find something that's helping us make progress. So it's cool. You're just, I appreciate you showing up and, yeah, reaching out for help. So Thank you, Sarah. All right. Nita. Nita says, I'm interested in having the gastric balloon done. Will this be surgery or inserted by mouth? I'm 71, I'm overweight, with diabetic, with HPB. Am I a candidate? So, great question, Nita. Um, Interested in having the gastric balloon? Great. Whatever, a gastric balloon is a tool we didn't really talk about. It's not really something we have offered at our practice for a while, and for a couple of reasons. The reason we don't currently do gastric balloons is that gastric balloons give a lot of nausea and they're pretty uncomfortable to have. And you can only have them generally for about 6 months. To answer your question directly, it is generally a procedure but not a surgery. So endoscopically, you usually go down and you place the balloon endoscopically, where you can get the balloon in there. You don't need to do any surgery, like in the sense of incisions, cut anything open, nothing like that. You place the balloon and you fill it up. I think so our practice doesn't do balloons currently, and for a couple, like I was saying, a couple of reasons for that. They're very uncomfortable for patients. This is probably one of the more miserable ones, and for patients, and the weight loss is tough to maintain. It's really tough to maintain afterwards. Um, there are places that do it, and there are people that have kept their weight off for sure. But I would say that's not the expectation with the balloon. If you are looking for the, it's always the question, right? Like, which one should I do? Which tool should I use? I generally recommend people use the most aggressive tool, the tool that has the best results, the best durability, and is the most cost effective. And generally, for most patients, and you would have to look at your certain situation, but something like a laparoscopic sleeve is usually the most effective, the most durable, and over time, the most cost effective. The endoscopic sleeve would probably be next. The endoscopic sleeve is generally not covered by insurance, though. I'm not sure if your insurance would cover bariatric surgery anyway. Depends on what your thing is, what you have. We can do benefit checks to see what that is. And then the gastric balloon, and then honestly, this is my feeling and my practice is that if you're going to do pay cash for a gastric balloon, I would probably counsel you to probably pay 6 months. And for 6 months, I would probably counsel you to pay 6 months for a GLP-1. And it's safer, it's less miserable, and it generally does well. So that's kind of generally where I would steer people. But if you're really interested and have your heart set on a gastric balloon, there are a lot of people out there that do well with it and can have used it well. So yeah, I am a person who believes in the best tool for you is the one that you want, is the one that you're cool with using. So thank you, Nita, for your question. All right, and no name was submitted with this one, but it says, I read a study about misshaped stomach pouches for a sleeve. How do you prevent that? I'm not exactly sure which study you're referring to, but yeah, you definitely don't want your pouch to be a weird shape. You want it to be nice and perfect every time. So what we do to take a lot of care with that is we make sure, number one, you have a full clean dissection around the stomach so you can fully see everything that you have. Well, maybe even I should before that. We start with doing a pre-op diet where we make sure we shrink the liver, we have some weight loss, and most of that weight loss actually comes from the fat around your intestines, so it gives us the most space to do the best and safest surgery we possibly can. That way we can see the stomach as best we possibly can. So starting from there, then when we do the dissection, we make sure we can completely see around the stomach so there's no hidden spots, no hidden pockets where the stomach is. I make sure that I completely see like the left cruce, where I can have complete mobility and complete visualization of all the stomach. Then you place a sizer, and then usually that sizer is a 38 French bougie, goes and sits in the stomach, and then you use a stapler device, and a stapler is a device that compresses the tissue, and then it lays down all these little staples inside of it and cuts. And that seals the tissue, and then it cuts. And then so everything's actually sealed. There's nothing that's leaked out, things like that. So it's a very precise way to do an operation. Very precise, very clean, and gets great results, honestly. And we're generally extremely happy with the way they come together. We really want to avoid misshapen pouches. And sometimes I see people come back with some I'm not sure where they got some of these things sometimes. And yeah, but we can kind of get them back in shape if that does happen, through any number of ways. But yeah, an ounce of prevention is worth a pound of cure for sure when it comes to what that is. Which is why you want to go to, if you're getting bariatric surgery, you want to go to someone who does this all the time, because um, if you're just dabble, and if you kind of like, hey, I'm gonna do the sleeve because it's fairly straightforward operation, it doesn't mean necessarily, you want someone who really does this a lot and really tries to get a really perfect result every time. So awesome, great questions. Let's see here. Got my phone. I think Chris was sending me another message. Yes. All right. So, do you do a liquid diet? Get that question all the time. Yes and no. So a lot of people mean liquid diet like a pre-op liquid diet, like I was kind of just alluding to, that liver shrinking diet. Many practices do a liver shrinking diet that's liquid, like protein shakes. We feel that that's a little bit. We don't do that. So we do 2 weeks of a low calorie, high protein, low carb diet. Give you specific instructions of what we want your specific macros to be, and usually that really helps us kind of make some good progress into surgery, sets you up for success. We have found there's some cases that doing liquid diet is important and helpful for people, but generally that um, it's not necessary. It's not necessary. Um, Liquid diets are nice though. There's a lot of benefit in liquid diets because you can just say, hey, here's your box of protein shakes. Have these for 2 weeks. So it's pretty straightforward. But we do that afterwards. So after surgery, there's a week of liquid diet, 7 to 10 days, where you're just on liquids. You're making sure you're getting your protein shakes in to get your protein numbers up, making sure you're getting your hydration. But generally, we're trying to let the stomach heal a little bit, not put under too much stress, or ask it to do too much before it's ready. After that, we do a soft diet or puree diet for about a week, then a soft diet, and then it goes on to regular texture food. Just your portion sizes are very small. As an example, in that first month, portion sizes are about a quarter cup. So, all right, cool. Well, that is all the questions I got in here. So I appreciate everyone's questions that they submitted, and yeah, we're here for you. You just reach out. We'd love to hear from you and help take care of you. I know obesity is really hard, and there's a lot of great tools now. So hope you have a great day, and thank you again for tuning in.